Hello and welcome to today's PIR live event webinar brought to you by Partners in Research Canada. My name is Stacey Joyce and I will be your host. If you're joining us live, please remember that you can ask questions anytime throughout the webinar, even during the presentation, by typing them into our sidebar chat. So to get there, you go to the top left corner of your screen and click chat. Once you're there, make sure that you change the to field so that it includes all attendees. That way the others who are joining us live can see what is being asked. Today's guest is Dr. Roger Zemek. He is a pediatric emergency physician. He is also an associate professor in the Department of Pediatrics and Emergency Medicine, clinical research chair in pediatric concussion at the University of Ottawa, and director of the clinical research unit at the Children's Hospital of Eastern Ontario. As you can tell, I had to read that off from my other screen there on the side because you have so many credentials, Dr. Zemek. From here, I will let you take it away.
Well, thank you very much, Stacey, and good morning to all the students. I'd like to get started with my presentation because what we're going to be talking about today is concussion. So I'm just going to make sure my share screen is on, and I'm going to do that for you. So what we're going to be talking about today is the topic of my research, which is actually concussion. So I know I can't see all of you necessarily in the classrooms, but what I want you to do is to raise your hands if any of you have either had a concussion or if someone close to you has ever had a concussion. Now, I would be raising my hand myself because I've had several concussions, and that's one of the reasons why I chose to study this area of research, because it's an area I'm very passionate about getting to the bottom of some of the questions that remain in this important medical field. So before we begin, I thought it'd be important for all of us to get on the same page on a definition. So let's spend a few moments talking about what is a concussion. So a concussion is an injury to the brain. So inside our heads, we have our skull, which is a hard bone, and beneath that skull is our brain, which is more of a jello-like substance. And what happens sometimes is when people can get either struck directly to the head or indirectly to either the neck or to the body, which causes the brain to shake inside that skull. And that's usually what we call an acceleration, meaning the speeding up and then coming to a sudden stop. So either people could be going really quickly and come to a sudden stop, or standing still and have something hit them, which causes the brain to be injured. Now, it's not an official bruise to the brain. Now, bruising, when you get a bruise on your leg or a bruise on your arm, it causes a black and blue, and that's just a little collection of blood that causes that color change. Now, the brain in a concussion does not actually bleed. That's a different type of injury. That's called a hematoma to the brain, and that's a different type of problem which usually requires surgery to get that blood out. Now, because of that, we define concussion more of an injury that we call affecting the function, meaning how the brain works, rather than the structure of the brain, which was something that shows up on a picture, like a CT scan or an MRI. And it's for that reason, for those of you who may or may not have had a concussion, we don't do typical pictures to diagnose concussion. It's a list of changes in how the people are acting or thinking or remembering afterwards that help doctors make that diagnosis. One thing that's changed over the years is that we know you don't need to lose consciousness to have a concussion. So what happens, in fact, is it's more of an injury to the cells of the brain. And the major cell of the brain is called the neuron. And this is a picture that kind of demonstrates what happens when the neuron gets injured. So during the injury, when the brain speeds up and slows down, potassium is an ion that normally lives inside the cell. And because of that stretching, the potassium rushes outside where it doesn't belong. And because it's out, things like calcium are able to rush in. And calcium normally sits on the outside, and that calcium on the inside can change things, leading to some dysfunction of the cell, and that will release these little chemicals at the end of the neuron called a neurotransmitter, and that will send perhaps the wrong signal to the next neuron. And that results in perhaps some of the symptoms that you're having and can result in an energy crisis because of this imbalance. And it can take days or even weeks for the cells to get back to their normal condition. This is what a concussion can look like. I live in Ottawa, and our most famous hockey player of all time is Daniel Alfredsson. And here's a video, and you see how he was moving quickly, and he was hit, and he spun quickly. He didn't get knocked out, but as you could see, he was initially confused, dazed, and had some problems with his balance. So hockey is a common cause of concussions, but maybe you guys can take a moment and I'll pause, and maybe you can raise your hands and tell your teachers maybe what you could think. What do you think some of the top reasons for concussions are? And I'll just pause about 30 seconds for you to just maybe take some participation with your classroom, and you could tell your teacher. So hopefully everyone's had some ideas about what might be some of the causes of concussion. And here are some of the list. So they're not necessarily the same for boys and girls. So the commons of sports are, again, soccer and ice hockey. Cycling's a common one, and some of the snow sports. But again, horseback riding is another popular one, especially for those of you who may be out in the West, like Alberta as well. So what are the symptoms of concussion? Well, we typically break it down into 4 main areas. You could have symptoms that can cause physical changes. Examples of those could be things like having a headache, feeling like you want to vomit, being dizzy, having a bright light or bright noises bother you. You could have problems that affect how you think. Those are called cognitive problems. So you may feel slowed down or feeling foggy, problems concentrating or remembering. Some children have emotional or behavioral changes. They're feeling more sad or more frustrated or more nervous. And finally, concussion can affect the sleep, having problems either falling asleep or problems staying asleep. So concussion can affect all different parts of the brain, and the brain really controls everything we do. So it's not surprising how so many different types of symptoms may be caused by this problem. Concussion is a really common thing that we see in the emergency room. As you heard from Stacy's introduction, I work in the Pediatric emergency department in Ottawa, and we see about 1,000 new kids with concussion a year. So on average, that's about 3 kids a day show up. So this isn't a real case. It's what we call a hypothetical or a vignette case. So it's made up of a type of case that we normally see. So I thought I would go over this with you. So let's say there's a 13-year-old girl, she's in 8th grade, and she collides during soccer. She did not get knocked out, which is a loss of consciousness. She remembers everything normally, but she was unsteady on her feet. She was slow to answer some of the questions her coach was asking her, and she had a headache and was feeling foggy and tired. So the coach did the right thing and took her out of the game. The mantra we use is, if in doubt, sit them out. And that is to make sure that you don't get another injury while you're recovering from that first one. And that girl then comes to see us in the emergency department. And in the emergency department, in the waiting room where there's a lot of people waiting and a lot of overhead announcements, her symptoms are actually getting a little bit worse. The noise and the lights. And when it's time to finally sit down and talk with the doctor, we learn that she has never had a concussion before. She doesn't have a history of prior headaches, sometimes they're known as migraines. When we do some testing to see how well she's thinking, she does perfectly well with that, remember, her ability to concentrate. But when we tested her balance, she had a hard time with some of her balance tests. Based on some of the rules, we decide whether people need a picture or not. We decided she doesn't need a CAT scan because, again, we don't think that there's any sort of bleeding in her brain. And so the doctor has diagnosed her with concussion. So the question that kids always ask is, when am I going to get better? So I'm going to ask you, I'm going to have you vote quickly. Who thinks she's going to get better really quickly, mean in a week or 2? Or who thinks she's going to take more than a couple weeks to recover? You can show hands. Who thinks she's going to recover quickly? And who thinks that she's going to take longer? So let's find out. Can we as doctors predict how long people are going to have their symptoms last after a concussion? And that's my area of research. So to answer this question, we got funding to do a research study across Canada. And the name of that study was called the Predicting Persistent Post-Concussive Problems in Pediatrics. And I know that's a mouthful, so it's called the 5P study for short. So you can see all the P's in the brain in our logo. So in the 5P study, our goal was to come up with a rule to predict how many kids would go on to have symptoms last for more than a month using factors that were available clinically. And what I mean is, yes, there may be some fancy genetic tests or blood tests or even some maybe advanced research pictures that we could do, but those would be available to everyone everywhere. So we wanted to use the things that are available to anyone, be it the emergency doctor, your family doctor, or even potentially even a coach on the sideline. So I know many of you may be spread across the country, and some of you may have even gone to some of these children's hospitals for care. So this was a true national effort across 9 hospitals, ranging from Nova Scotia all the way out to the Rockies. We did a lot of questionnaires to our patients who, when they presented to the emergency department, we asked them about their symptoms, what sort of symptoms they're having at the time, and we asked their parents as well. Because sometimes kids say that they're concentrating normally and the parents can tell that they're not their normal self. We actually tested how well they remembered things by asking them a list of words. So, for example, we would give the words finger, penny, blanket, lemon, and insect, and then we'd see how well they remember, and then we'd check them a few minutes later as well to see how well they'd done with remembering that list of words. We'd also give them a list of numbers and see how well they could concentrate to do them backwards. So for example, if I said the number 493, the person would read back to me 394. And if they got that right, we moved to the next number list, and the list would get longer and longer until to see how well they did. For this one, I'm going to have you all stand up. And hopefully you have some room by your desk to do that. One of the things that we do is do some tests of balance. So I'm going to have everyone stand up. You can keep your shoes on. I don't want to have you take off your shoes. But the first test you're going to do is you're going to put your hands on your hips, your feet together where your big toes are touching and your heels are touching. And you're going to put your hands on your hips and you're going to just bend your knees slightly and look straight ahead. And on the count of 3, you're all going to close your eyes. 1, 2, 3. And as your eyes are closed, I'll describe to you what I'm looking for. I'm looking to see if you open your eyes, if you take your hands off your hips, if you sway too much, if you take a step. If you do any of those things, it counts as an error. And what I would say is you keep trying, if you get out of position for whatever reason, you go right back in. So everyone can open their eyes. Don't sit down yet because we're going to do the slightly harder test. Now everyone's going to pretend there's a little soccer ball in front of them. And you're going to give it a little kick. And the foot that you did the kick with is the foot that you put in front. And I now want you to pretend that you're walking on a tightrope. And I want the toes of your behind foot to be touching the heel of the foot in front of it. And again, get in that same position with your hands on your hips, your knees just slightly bent, your feet walking that tightrope, and try to hold that position. And on the count of 3, you're going to close your eyes again. 1, 2, 3. This one's going to be a little bit harder. You may find yourself, you take your hand off your hip for balance, or you sway, you have to take a little step, or you open your eyes. That's okay. Get right back in. You're more than half done already. And now you only have about 5 seconds more. 3, 2, 1. Great. So you can all open your eyes and have a seat. And this is what's called the Balance Error Scoring System Tandem Stance. So one of the things we also did was we asked questions about how they feel now versus before the injury. Because if I were to ask you in your classroom right now, some of you may feel a bit upset or tired or feeling that they're a bit more emotional the last few days. And it may have nothing to do with the injury. It's just the way, how you're feeling today. So what we really want to focus on is how you're feeling today versus how you normally feel before an injury. So what did our results show? Well, we enrolled over 3,000 children with concussion across Canada, and they were aged between 5 years old up until 17, up until their 18th birthday. And what we found is about 2 out of 3 kids have their concussions due to sports, but about 1 in 4 have their concussion due to non-related sport injuries, like falling or slipping on the ice. I know that's really common here in Ottawa when we have our icy, snowy days. And with regards to sports, you could see here are some of them, but there's lots of other sports that we just didn't list. Most kids get better, so that's the good news. But we know about 1 in 3 kids continued to have symptoms at about 4 weeks. And what was important to us was to try to figure out who was at risk for that. So we looked at all the factors. There were about 70 different things that we looked at individually to see which ones were predictive, and then we took those that were predictive on one-on-one and then combined them into a special type of analysis where we looked at them all at the same time. And that's what I'm going to show you the results for here. And then what we did was we assigned points to whatever, depending on how powerful of a predictor it was. So it really breaks down into about 5 main categories. So the first category is basically who are you, how old you are, and whether you're a boy or girl. And as you can see, the older kids seem to be at higher risk than the younger kids. And interesting, girls seem to take a little bit longer to recover than boys. So girls are a bit higher risk. The next question is their past histories. So we asked, did they have a prior concussion and how long did they take to recover? And did they have a history of prior migraine headaches? The next category is a quick cognitive test, meaning how well are they thinking? So are they answering questions slowly? And if so, that increases their risk. The next most important predictor is that test I just had you do where you walk that tightrope, that tandem stance. And many of you may have had an error or two. That's normal. The question is, did they have more than 4 errors, or were they unable to get into the position and hold it, or unable to stay in that position for at least a certain number of seconds? And for those, that's an important predictor to see how quickly they recover or not. And then of all those symptoms I showed you earlier, it really breaks down to these 3 most important, whether they had headache, sensitivity to noise, or feeling tired. And with that, you can add up the points. The minimum number of points is 0. The maximum number of points is 12. And we know when children's points are greater than 9, they're really high risk of it lasting more than a month. And if their points are 3 or less, we know that they're going to recover quite quickly. So let's go back to that case. We knew that she was a 13-year-old girl who never had a prior concussion or migraine, but she answered questions slowly. She had problems with her balance, and she had headache, sensitivity to noise, and fatigue. So her point total was 10, which actually puts her at high risk. She's actually at a higher chance of having a longer recovery. I talked about a lot of science in this, and one of the things that we do as scientists is we do a whole bunch of advanced analysis, and we then submit it to other scientists to review to see if our work is sound. And the journal that we submit to for this study was the Journal of the American Medical Association. And some of the journals are only in print only. This actual paper is free, available online for download. So if some of you want to go and look more to see what all the sports were, or the different age groups, or what the other factors were and the actual numbers to see how strongly the predictions were, you can go and ask your teacher. Maybe they can download this if you want to talk more about this later. So what happens next? We know she had a concussion. She came to the emergency room. The doctor said, it's important that you recover and rest. And some kids, or their parents, interpret this as they need to stay in home jail. And we know that that's actually probably not the best thing for you. So what do we need to do? Well, we know we could do better and have to do better to do that. So what are the next steps for our research? So we know actually just over the last couple of years, staying in bed for weeks and weeks on end is probably going to lead to worse outcomes than doing a little bit of activity. Now, I really want to emphasize that we are not encouraging anyone to go back to their full hockey game or their rugby practice or their football or even going on a bicycle or skiing until they've been checked by their doctor again, because we don't want someone to bang their head while they're not fully recovered. But things like going for a walk or a stationary bike or going for a slight jog, like in step 3, those things can actually help you recover faster potentially. So again, to do that full contact practice or events, types of activities which can cause you to fall, you need to get your doctor to be cleared. But for things that are not going to increase your risk of injury, doing some physical activity has actually been shown to help you recover more quickly. It's been an absolute pleasure to speak with you. I'm just one person on a many member team. And that's the thing about research. It's a teamwork. Sometimes in class you have to do projects where you pair up. Well, as scientists, we pair up as well. And here are just many of the people that have worked with me across the country to make this research possible. So here is our City of Ottawa. I'd be happy to take any questions if you have any. Thank you.
Well, thank you so much. I think that was really informative. I know I learned a few things. And now I feel like later today I have to try standing with my one foot in front of the other and see if I can stay stable. I think the very first question that we have is how common are concussions in adults versus kids? We talked a lot about children. What about comparing the two groups?
So interestingly enough, there are more concussions happen in kids as compared to adults. And it's probably because, to be honest, kids are a bit more active. Many kids are doing their gym class and they play at recess and they have their organized sports either through their school or recreational leagues. Whereas adults, during their day at work, many of us don't get recess, and many of us, while we do sports, are not often doing some of the sports that are put us at higher risk. So in general, kids do get more concussions than adults. The number of concussions have gone up a lot over the years. I don't think it's because kids are more fragile, or I don't think it's because kids are doing riskier activities. I think we're just better at recognizing the number of concussions, and people are being brought to their doctors to get checked after them, whereas before, for many years, people were just saying things like, oh, you just got your bell rung, you'll be fine, get up and get back in. And we now know that that's probably not the right thing to do.
Right. And before I ask the next question, I'd like to just ask you if you can hit the stop share button on your screen. That way we'll see
Certainly.
your video a little bit larger. Perfect. We talked about protecting someone with a little bit of rest after they've suffered an injury, they have a concussion. Why is this so important? What happens if someone who is suffering from a concussion currently and still symptomatic receives another blow to the head? What if they hit their head again?
So let's talk first about the rest. As I showed you in the first few slides where I showed you the picture of the cell, we know that there's kind of an energy crisis that happens with concussion. And what I explain to patients is, if you think about how you work your day, many of us get to school or to work in cars, and our cars run on energy, which is a gasoline. When you have a concussion, it's kind of like you're starting your day on a half or even just a quarter of a gas tank. So there's only so much time you have, or only so much energy you have over your day to spend to do the things you want and need to do. And so if you spend your day not resting, and you spend your day doing video games or doing things that tire you out too much, there's not going to be the energy to maybe go to school for a part of the day, or maybe not to go for that walk. Some of that energy at your brain that you have when you eat and produce more energy, some of that energy has to be used to repair itself. So that the brain is using some of the energy for that. Right. And so therefore, if your brain still has not yet recovered and you get another blow, that metabolic energy crisis can get worse. And as I told you, some of the signals get mixed up, and while in some people it can lead to confusion or headache, well, if your brain's injured and you get the signals mixed up, your brain also controls things like your blood pressure and your breathing. And so what we don't want to happen is a type of injury where your brain is getting mixed up for the things that actually help keep you alive.
That does sound quite serious.
Yes, it's called the second impact syndrome. It's very rare, but when it happens, it can be life-threatening. Right.
So this would be why so many people are extra cautious, I assume, after a concussion. They really want to rest. So what advice do you have for a student or their family when they've suffered a concussion, they're in that rest period? How do they know when to become a little bit more active, and how can they safely get back to their level of activity if they are a soccer player or a hockey player, etc.?
So what we now say is that the best plan is to probably take 2 days where you're taking it easy. And that's going to be both thinking, taking it easy, and physical, taking it easy. So if it happened, let's say it happened at school on a Monday, maybe you don't go to school on Tuesday or maybe even Wednesday. And then as you get back to it, maybe you start with just a couple hours a day, and then you expand to more hours, to a half day, to a full day. But even though those full days, maybe you don't have to take any tests while you're still recovering. Most schools I know in the province of Ontario have have each developed a plan on how kids can return to learn, we call it. With regards to the physical activity, again, for many years we thought, oh, just full physical rest is best, but we now know that that's probably not the case. And after a couple days of rest, most kids should be getting up and just going for a walk. They may get a little bit of headache, they may get a little bit of symptoms. What we say is, can you tolerate it? There's many people who get injured in other ways. They break their arm or they sprain their ankle. We know that walking on that ankle is going to help that ankle return more quickly. So the first few steps after you sprained your ankle may still be a little bit sore, but it's part of the recovery process. And kind of the same thing for concussion. What we really say is, it's kind of like that old Goldilocks story. We don't want it too hot, we don't want it too cold, we want it just right. So we don't want them completely going right back to their full sports where they're going to be at risk of injuring their brain again, and we don't want them overdoing it by, for example, running a marathon the next day, but we also don't want them sitting in bed for weeks on an end. So finding that just right balance, and that's actually one of the research that I'm leading right now. We're doing a study which is called a randomized controlled trial, where some patients, when they show up, one are assigned to one group and one's assigned to the other, and we're actually comparing two different types of return to physical activity plans, and we actually are sending the kids home with a medical grade Fitbit. So not one that they wear on your wrist, but a medical grade one, which has really a very, very fancy ability to measure all the movements and how fast you're moving and for how long, and can even measure how well you're sleeping. So that's a study that we're doing right now across multiple centers as well, and hopefully we'll have a better answer of what's the ideal balance between the different types of rest and activity.
We'll have to stay tuned for the results of that one. I know many parents will be interested to know what the best course of action is for their children. I want to change gears a little bit before we run out of time and ask you a bit more about your career path and your role as an emergency medicine doctor. What did it look like on your way to where you are today? Maybe what got you interested? What can students expect if this is something they might want to pursue?
So first thing is, I love my job. It's a lot of years of studying to get to where you want to be, but in the long run, it's worth the effort. So just to explain to the students, the way it works to become the type of doctor that I am, or other types of doctors, is after you finish high school, you then go to university. Typically, most doctors go to a 4-year university, and some will study on certain topics. Some will be a biology major, others may go into others, but you don't have to even study science. I have friends who are doctors who studied literature or certain languages. I was a mathematician in university, so I had a degree in applied mathematics. After that, I applied and got into medical school, and medical school is 4 years. What you typically do is the first 2 years are really focused mostly on book learning, and then the second 2 years are in the hospital. So what you do in the hospital is you go through all the different types of doctors that you could be, and you spend about a month to 2 months in each of those, depending on your school and what type of curriculum they have set up, but you rotate through all the different things. So even if you know you don't want to be a surgeon, you still have to do a month or two of doing different types of surgery, and you do all those different rotations. They're called clinical clerkships. And after you're done with med school, you apply to what's called a residency. And that is where you're basically an apprentice. You actually have your medical degree, so you have the letters MD after your name, but you're not yet licensed to practice on your own. So you have to work in a hospital setting under the supervision of other doctors in an academic center. And depending on what type of doctor you are, it could be more or less years. So family medicine, for example, is a 2-year program. I did pediatrics, and what I did was I did 4 years of pediatrics, and then I did what we call subspecialty training, which was then additional years, and then I did another few years of pediatric emergency, which is called the fellowship. So for me, it was 7 years after med school, plus 4 of med school, so that's 11, plus 4 of university, which is 15. So it's a lot of years, but you can do it a bit shorter depending on what type of doctor you want to be, but it's been well worth it, and I love the chance to interact with the patients when I see them. What I kind of, in the emergency room, we have no idea what's going to show up. It could be an infection, it can be an injury, I could be having to sew a laceration one day and fix a broken arm the very next patient, and figure out why a child has a fever the next. So there's a chance to do all different types of care. And then again, in my research, I'm able to answer the questions that are most important to my patients, because those are the ones that really are the ones that give us the most drive to get the answers for. And I found that in concussions, the parents really wanted to ask me these basic questions of, when is my kid going to get better, and when can they go back to their sport? And I didn't know the answer, and other doctors didn't know the answer. So that's why we research these things.
Right. And it sounds like, of those 15 years that you spent after high school training to do what you now love doing, it doesn't sound like it was all more school the way we think of that. It sounds like after the first 2-3 years that you were basically practicing.
Yes.
Is that?
Yeah. So when you're in medical school, those third and fourth years, you just show up each day to the, and you may still have to go home and study a little bit around your patients or read a bit more. There may be assignments that they have to give you to write up cases or give a report on a certain thing that you've just learned about to your peers. But it's really, you're being a student doctor, we call it. So that third and fourth years of med schools, you're really being a student doctor, and your years of residency, you actually are a doctor. You're just, you're there. The reason, I'll give you a little joke, well, it's not a joke, it's actually true. The reason they called it a resident was, for many, many years, when you were assigned your residency, you actually lived at the hospital. So you didn't live at home, you didn't have an apartment, your apartment was the hospital. There was a cot or a bed for you, and you were on every single day, all day, all night. Now the rules have changed, and we don't abuse our student doctors so much like that anymore. So what we do is we have a call schedule, and they still work really long hours, but they don't have to sleep. They don't have to permanently sleep in the hospital every night anymore.
That sounds maybe a little bit more manageable.
Much better.
For a trainee. The very last question I have for you, Dr. Zemek, is about collaboration. So we may have students who might not want to go through the long gamut to become a doctor. Maybe they're more interested in the research. What kind of people do you collaborate with in order to make these things happen?
And that's a great question. We have lots of people on our team. Some of them have become medical doctors, but others are doctors as well, but they're scientist doctors. That's often called a PhD. And some of the PhDs I work with are people who are expert in doing the analysis with regards to the math, and those people are called biostatisticians. So those people, all day, they work with the data that's been collected by the different scientists, and they help the researchers figure out what is showing a result and what is not. Other types of PhDs I work with are people like neuropsychologists. I work with exercise physiologists. I work with kinesiologists. I've worked with occupational therapists and physical therapists. So there's lots of people that I work with who don't necessarily have a medical doctor degree, but they're still have advanced degrees and are wonderful people. And I think that's what makes our research so wonderful, is that I get to work with people of such great perspectives and backgrounds, and everyone contributes an important part to get to the bottom of these important questions.
Well, thank you so much for joining us today. I know we've already run just a little bit over time, but so many great questions to answer. Thank you so much for informing us about concussions and answering our questions today.
My pleasure.
Next week on PIR Live event, we're actually taking a spring break, but join us after break on World Water Day, March 22nd, for a discussion of microplastic pollution in Canada. More information on this webinar and other PIR educational programs is available at pirweb.org. Thanks so much for joining us today. Have a great one, everybody. Bye.